video, let's discuss about the posterior crossbite. So basically, it is a buccolingual tooth inclination. Now, if the upper posteriors they are inclined palatally, it is favorable. Improve inclination as posterior is tipped buccally. All right. Now, if it is inclined buccally, it will be basically due to a narrow maxillary arch. It could be more stable if teeth are tilted palatally initially. Now, in etiology, it can either be due to displacement of one tooth or it can be due to the reciprocal movement of the two or more teeth. Now, in case there are many vertical changes also, such as we see that there is tipping down and the mandible, it rotates the downward. So, there is increase in the lower facial height. Now, coming on to the treatment modalities. Now, first of all, what we can use is the crossbite elastics. Now, these elastics, these are attached to the maxillary palatal surface and to the mandibular buccal surface. All right. So they are basically used for the molar teeth. All right. Now single tooth basically they're attached to the maxillary palatal surface and mandibular buccal surface. All right. Now these are basically indicated in places where there is sufficient space for moving teeth, also worn day and night, also less than equal to 6 weeks only, otherwise it will extrude the teeth. Now second modality is the coffin spring. Now coffin spring is an omega shaped spring. First of all, it was given by Walter Coffin. Now it is an omega shaped wire of 1.25 millimeter diameter placed in mid palatal region. The free ends, they are embedded in acrylic plate which covers the slope of palate. It can bring skeletal changes in young patients, but definitely brings dentoalveolar changes, basically expansion. Now the third treatment modality is the quad helix. Now in this there are four helices by the name only. We can see it brings the dentoalveolar expansion, skeletal changes in young patient. Okay, we can use it in adjunct to the fixed orthodontic therapy. Now, the fourth treatment modality is the rapid maxillary expansion, which is RME, used in bilateral skeletal crossbite, basically deep palate, nasal obstruction, and narrow maxilla. All right. Then we can also use removable plates. In removable plates, there is midline jack screw, split acrylic plate, Adam's clasp on posterior teeth for retention. So this completes our crossbite topic. Thanks for watching. I hope I made it easier for you to understand. But yeah, there is also one flowchart which we can use to explain the posterior crossbite, which I'll be discussing in this video only. So basically, we have posterior crossbite in centric occlusion. So we evaluate in centric relation. Now, if it is bilateral, if centric relation is equal to the centric occlusion and there is bilateral crossbite in centric relation and centric occlusion with no shift. Okay. Now, if there is centric relation equal to centric occlusion, bilateral crossbite, plus there is shift to unilateral in centric occlusion. If there is unilateral and there is basically similar, you have to write the same thing but with unilateral. unilateral crossbite in centric relation and centric occlusion with no shift. All right. Now, these are the three things that can be there. Now, in this, we will evaluate maxillary, arch, symmetry. Now, symmetrical, asymmetrical, bilateral constriction of maxilla, or true unilateral constriction of maxilla. All right. Now, primary dentition, mixed dentition, young adolescent, and adult. Now, in primary dentition, what we will do is for this phase, I'll write it on the I'll write it on the next one. Primary, mixed, young adolescent, and adult. For this one, we will first of all we will remove the occlusal interferences. Then we will correct functional shift. We will expand the arch with appliance. If it is mixed, interception of habits, occlusal equilibrium, expansion. If it is young adolescent, we will do RME with jack screw. If it is adult, so we will have to do surgically assisted R rapid palatal distraction or expansion. All right. Now, if it is asymmetrical, where there is case of true unilateral constriction of the maxilla, so we will first of all in the primary dentition we will postpone the treatment if there is no functional shift. If there is no functional shift. In mixed dentition, we will maintain an occlusal equilibrium, interception of habit. Then we will use quad helix or W arch. Alright, in young adolescent, we will cause unilateral expansion mechanics through unilateral elastics or expansion devices. In this unilateral expansion, assisted by orthodontic surgery. So this completes the crossbite. I hope you understood. Thanks for watching.